guys. Hello. This is Gillian McCormick here, and I'm a pelvic health physiotherapist, and I'm going to be here on the Menopause Chicks private online community for the next hour to answer your questions about pelvic health physiotherapy. What's the experience like? What should I go to one for? How do I treat something like urinary incontinence? I'll do my best to answer your questions. So if you have questions, I think you can jump on and create comments. And I know that Shirley Weir, our fearless leader, is out there somewhere, and she's going to help us out managing some of the comments for me and throwing questions up. So let's get started. Hi, Shirley. Hi, honey. Okay, so fun. I'm going to be playing with various lighting and props while we go. Okay, so first, a little bit about me. I'm a physio who's been practicing for just over 20 years. I find it surprising to say that sometimes. I am definitely deep within my own perimenopause, so some of this stuff has been relevant to me over the years. I have been a pelvic health physiotherapist for 16 of those years. So I've been in here a long time. I treat both men and women. And so what this means is that I got my certification to be a physical therapist. So I'm licensed and registered as a physiotherapist. And then you take courses on weekends, postgraduate courses, to learn how to assess and treat pelvic health dysfunctions. My way in was that I told myself I was going to treat women with urinary incontinence. They at least had anatomy in common with me, so that was a bit less scary to consider, talking about very private things and women's private parts with them. And then you start that. And by the way, pee is quite clean. It itself is sterile when it comes out of you, so that intimidated me less than fecal incontinence. But often pelvic health concerns like incontinence, both of urine and stool, pelvic organ prolapse, which is a falling down or descent of your pelvic organs, and pelvic pain go together. And so my clients would come to me and they would say, okay, I do have urinary incontinence, and I also have this and this and this, which meant that I had to be brave and start learning about all of those other types of dysfunctions and how to treat them. And it's been a Pandora's box. You dive in and it's a fascinating place, very meaningful group of clientele to work with, and I've enjoyed every moment of it. So I don't only treat people in their menopause or perimenopausal time. I also treat women around their pregnancies, delivery, and postpartum. I also treat young women, teenagers with pelvic pain throughout the lifespan. I treat women who have pain with intercourse, which can definitely pop up in your menopausal years. Let's see, issues with endometriosis. Yes, so I treat men and women. So actually, I've got a couple of drawings here to teach you some anatomy, and I'll just pop this up right here. Hopefully this is easy to see. So this is a woman's pelvic floor, and I'm going to teach you all about what those parts are. Which way is up? And then this one is a man's pelvic floor. And if you put them side by side, aside from one extra opening, they're really not that different, okay? But men don't typically have issues with pelvic floor dysfunctions as early in life as women, or as commonly as women. They don't have that extra hole that's built in down there. They don't deliver the babies, right? And they tend to have issues with their pelvic floor to do with incontinence and urinary hesitancy and erectile dysfunction later in life when their prostate starts to change. Okay, so definitely good reasons to see a pelvic health physiotherapist if your spouse or a male friend of yours is having those kinds of problems. In Canada, well, I'm going to say in most provinces, I'll admit that I'm not totally sure about all provinces in Canada, You do not need to go to your doctor first. You can refer yourself directly to physiotherapy care if you believe that you have a problem like this. And the physiotherapist can take your history and assess you and let you know whether or not your problem is amenable to physiotherapy services. Okay? All right, so no questions just yet. Oh, yeah, that's those two comments. I did see a couple, but I think if you ladies who have already posted questions are on here, I will answer your questions in time. Okay, so this is a woman's pelvic floor, and I'm gonna just move my own body out of the way a little bit. Sorry, wiggle, wiggle. Whoa, camera concerns. Here we go. Sorry about my light. Let's make that light a little more indirect. I hope you can still see. Yeah, that's better. Okay. So this is looking like the doctor would look when you go for your annual pelvic exam, okay? So pubic bone, where is it? Is up here somewhere. Tailbone is down here somewhere. This is one sit bone, and this is the sit bone on the other side. The whole diamond-shaped area of like pink pardon me, here we go. This is harder than you'd think. These are your muscle bellies, this whole diamond-shaped area. These guys down here are glutes. So they don't count towards your pelvic floor. Glutes are fantastic muscles, but not for holding in your pee, okay? So that diamond-shaped area are the muscles of your pelvic floor. Starting at the top is your clitoris. Your clitoris has a hood over it, and that hood needs to be able to retract for us to have a full sexual experience, okay? Sometimes when we don't have enough hormones around, or we have skin conditions like lichen sclerosis, pardon me, yes, Josephine, this will be available to watch later for replay, absolutely. Okay, so if you have a skin condition called lichen sclerosis, for instance, or some of the skin changes that happen if you haven't had estrogen near your vagina in a long time, your clitoral hood can become fused down. Then it doesn't get out of the way when your clitoris becomes engorged during sexual excitation, and that can be a source of discomfort and pain, okay? So here we go, that's one. Urethra is underneath it. It's a really, really small opening. You have to part the labia to find where it is, but it is a totally separate system from your vagina. You don't pee out of your vagina. Probably we know that, but I would just like to clear that up just in case. Then, of course, is the vaginal opening where maybe a baby came out of. And all these muscles around it, that's part of your pelvic floor. This is a drawing. It makes it look like your pelvic floor is very two-dimensional, but this is actually 3 different layers of muscles that make a 3-dimensional structure up and inside your body. It's really, really fascinating, perhaps just to me. Okay, so this is your perineal body. It's the in-between us. And then, of course, your external anal sphincter where the poo comes out. All of the muscles in this area are meant to contract at the same time. So I'm going to find here, contract, yeah. They're all meant to relax at the same time. But there is a right and a left side due to the nerves that feed the muscles. So we can see imbalances between the right and the left sides, and we can see imbalances between the front and the back. Okay, everybody with me so far? Let's see if I have any more comments. Oh, hello. Yes, thank you. So I'm gonna just answer Eleanor's question for a moment here. She wants to know how to find a pelvic floor physiotherapist in her area, which is in Richmond, BC. And if you're in British Columbia, Eleanor, what you do is you go to a website called bcphysio.org. So again, that's bcphysio.org. That is the Physiotherapy Association of British Columbia's website. And when you open the page, in the top, that's my right-hand corner, so yes, the top right-hand corner is a Find a Physio function, where you get to put in any of the details that you know, maybe a name, or if you scroll down and you enter in Richmond, which I actually did this right before we started. If you enter in Richmond, and then you enter in pelvic health physical therapist, there's a category of like, what kind of physiotherapist are you looking for? You can choose physios that treat incontinence. You can choose physios that treat pelvic pain. Those physiotherapist locations will pop up. Okay, and I think there's something like a 20-kilometer radius. So you get all the ones in Richmond, you also get all the ones in Vancouver and the North Shore, probably 32. And there's some great pelvic health physical therapists around the area of the greater Vancouver area. These have been my colleagues for many years. So that's how you find a physio in your area. I'm going to see if that's a bigger comment. Yes. Hi, Shawneen. You've been told to go see a pelvic physio to help with incontinence. So what do you expect at your first visit? What are typical results and how quickly are they experienced? And if I go once, do I have to keep going indefinitely? Okay, great question. So when you go to your first appointment with a pelvic health physical therapist, that physical therapist needs to get to know you. They need to get to know the history of the problem that you're having, and also your full medical history, because we need to try to figure out what are the reasons for you potentially having incontinence, which is leaking pee at any time that you don't mean to leak pee. Okay, there's a couple different kinds of urinary incontinence. There's stress incontinence that happens if you cough, laugh, move. There's a stress inside your body and you leak a little bit. And there's also urge incontinence, which is you have a strong urge to go pee and you don't quite make it on time. Your bladder gets away without you. Often those two problems are mixed. And so it's very common to have kind of a bit of both. So they're going to want to ask you a detailed history. They're going to want to do a physical exam. Now, in my case, I often will do a whole body assessment first because I need to see how all of your body is working and well and put together. The pelvic floor muscles are fascinating muscles. They work really well. They're very cool, but they're only one muscle group in the middle of your whole body. And so sometimes the reasons why your pelvic floor muscles are not working for you are related to a problem within their structure itself, but sometimes they're related to a problem that's in a different region of your body. And without kind of knowing what the lay of the land is, it's hard to plan for you the best, most efficient pathway to regaining control of your bladder. At some point, either in the very first visit or in the very next visit, you're going to have an internal assessment of your pelvic floor. And I'd highly recommend this. Some practitioners may try to pull out a real-time ultrasound and they take a picture of your bladder through your belly, and they can do it through a perineal view as well, which is they put it on the in-betweenus, the wand of the ultrasound, and they can look at the structures inside and see how the muscles are making those structures move. But there's some details with that kind of assessment that really can't be fully realized unless you do an internal. So if you're the kind of person for whom an internal is impossible, there are ways to have your pelvic floor assessed, but the best way, the gold standard, is going to be to have an internal. So then you would expect that you'd be laid down on a table. It would be a clean and covered surface. You would have you would be covered well, draped is I think the word I'm looking for. Your practitioner would use gloves and likely some kind of lubricant, depending on what your preference is, just to make it comfortable. We would take our time and explain every step along the way to make it as comfortable as possible. It is quite an intrusive assessment. Some stranger that you don't know putting their hands inside your private parts is, of course, a challenge, but we're trained very well to do this with respect. So then we need to figure out, are your pelvic floor muscles contracting? Are they strong enough to impact your bladder? Are they strong enough to lift your organs up and inside? Do they have enough endurance? Do they move quickly enough? Do they have any pain associated with them? And what is the best way for you to think about turning on your pelvic floor muscles? And then you'll be given some exercises. Pelvic health physical therapy can be very impactful almost immediately if what you have is a confusion about how to use your pelvic floor, and they clear that confusion up. Here's how you do it. Yep, that's a good job. Now do that every time before you cough, sneeze, or laugh. In 70% of women, that will cure or greatly improve their incontinence within a week. Okay, so it can be highly effective. No, you will not need to go back to a pelvic health physical therapist indefinitely, but strengthening a muscle group that is weak takes a period of training time. So you can assume maybe you might have 1 or 2 visits and that clears up your problem, depending on what it is, or you might need a period of like 6 to 12 weeks to really strengthen that muscle. And for some individuals, there's a constant coming back, annually or every few months to check in and just make sure things are going okay. Okay? All right. I think I did that one. I'm going to look down here. Yeah, Eleanor, if you have incontinence, if you have lichen sclerosis, which I've mentioned, a skin condition involving the labia and the vulva, if you have pelvic organ prolapse, if you have IBS, a pelvic floor physiotherapist may absolutely help you with those concerns, 100%. How many visits through extended health care that you may have in a year really depends upon your own individual plan. So that's not a question that I can answer for you today, but if you go to find a physio and you find a clinic in your neighborhood you think you'd go to, you can call that front desk and you can ask them to tell you what your benefits will extend to you. Okay? There it is, bcphysio.org. Thank you very much. How long or how many pelvic floor appointments? Yeah, to see an improvement in painful sex. Okay, so this is a great, oh, there you go. And the Vagina Coach has a directory there at Pelvian Wellness. Fantastic. Yeah. Okay, so before you see significant improvement with painful sex, so let's talk about painful sex for a moment. Reasons for painful sex. So here is your vagina, and there are lots of muscles around it, as you can see, right? So to have sex that is not painful, the tissues and the muscles in this area need to be able to stretch and accommodate to the size of whatever's going in there. And everybody may have different kinds of sex these days. So whatever you want to go in there. So it can be if what you've been doing is muscle guarding for some reason. You just have a really tight pelvic floor and you don't know the way to relax it at the key moment. Maybe it's just a couple of sessions where I teach you how to use your pelvic floor properly and when to relax it and how. And then you go home and you practice that. It can literally just be like that, okay? If the reason that you're having pain with intercourse is to do with your vaginal tissues, maybe they are having some vaginal atrophy because they haven't had enough estrogen on board for a while, vaginal dryness, trickier. You need to treat that first. So that can be using a vaginal moisturizer, and I know that Shirley Weir has educated all about vaginal moisturizers. Well done, Shirley. And or using a vaginally applied estrogen therapy for a period of time, probably at least one full tissue cycle, which would be about 4 weeks, sometimes maybe longer, so that your body can make new vagina cells in an environment that has estrogen around. It makes a better vagina when there's estrogen around. That's why estrogen is wonderful for these tissues. If there's hyaluronic acid around in a great vaginal moisturizer, that too is like one full skin cycle to at least allow those tissues to take in the goodness that you are giving it and come up with better tissue. Okay, so that's step number 1 for that population. And then you may still need to retrain your pelvic floor muscles. I do this all the time in my practice, especially the retraining the pelvic floor muscles part. When you've been in a situation where you may have had intercourse pain for a long period of time, because it hurt and then you tried it again a different time and then it hurt again and then you tried it again, it hurt again, your nervous system starts to want to protect you from that, right? That becomes a threat, a threatening situation. And so what do muscles do when you feel threatened? Do muscles relax when you feel threatened? No, they don't relax when you feel threatened, right? Muscles contract when you feel threatened. So every time you even think about having sex at that point, these muscles unconsciously are already protecting you. And they have to do the exact opposite thing. So breaking that cycle down in your nervous system is part of what a pelvic health physical therapist will help you do in a manner that is not threatening and therefore not painful. I'm not going to tell you that it's always comfortable, because some of this stuff is uncomfortable work, right? This is a hard area to work on. It's hard, but it's not painful. And provided that you go with an open heart to a physical therapist, be as honest with them as you can about any concerns that you have, you should find that you are well received within that, that your fears are listened to, and that you're given strategies to help you with those fears. So I'm sorry, I'm going to pop off for 1 second because I need to show you something. Okay, I'm back. One of the things we use when we rehabilitate people with painful intercourse are something called vaginal dilators. I really take offense to the name dilator, but it's what they chose to call them. It's more of an accommodator. This is a vaginal dilator or accommodator. It's made of wax. It's totally inert. It doesn't have a wick, but it could be a candle without a wick, right? These are ones that I often recommend my patients get because they're not that expensive. About $65 for the set. You get 7 in a set. You can see that one of these is bigger than the other. But the set actually comes with really, really super skinny on one end of the box, and they gradually increase in size to kind of scary at that end of the box. What we do is we teach you, using the smallest size that you can insert without pain, how to insert something inside your vagina that's not painful. And when you achieve a certain size, not the smallest one, but number 2, you can start to use this as a foam roller for your pelvic floor. Literally, an internal pressure massage device to help the muscles learn to relax, okay? And doing this over a period of time, like I said, can be 6 weeks, might take a little bit longer for some people, can be totally less than that for others, can radically change your intercourse experience. There's way more kinds of those kinds of dilators, by the way. These are just the ones I like to recommend. There's plastic ones, silicone ones, you name it. Okay, here I go. I'm going down in my comments. Yeah, muscle guarding is a reason for painful sex. You know, we do often think that our pelvic floors are probably just all weak because we've been told, like, by everybody forever that a weak pelvic floor, that you need to do your Kegels and Kegels and Kegels. And I have to tell you that one of the pitfalls of thinking that way is that you do Kegels and all you think of ever is on. I must turn them on, I must turn them on, I must turn them on. But in reality, a muscle in good health contracts when it's needed and then relaxes again. And it's very important to allow your pelvic floor to do both. So if you're doing, say, any pelvic exercise, or Kegel as they're called, or Kegel, depending on how you like to say it. And you know, some people are given an image in their mind of picking up a blueberry or an elevator that goes up various floors, and you're supposed to squeeze your pelvic floor muscles even more as you go. I also want to really emphasize that once you've done your contraction, you need to fully relax your pelvic floor. Give it ample time to rest before you try the next contraction. Okay. Okay, what else do I want to talk about here? So this is a diagram of I'm going to try to make it straight, which is really weird. This is harder to do than you'd think. Okay, so this is a diagram of our pelvises if we were cut in half, okay? So at this end is your pubic bone. The pubic bone is a brilliant little bone that you don't think of much. However, it provides a little shelf for your bladder, which is right behind it. If you are standing with your pelvis in a good pelvic position. So posture is really important when it comes to things like incontinence and pelvic pain and using our pelvic floor muscles well. You want to have neutral pelvic posture. And again, it's really hard for me to show you what this looks like. Most of us stand with our butts tucked underneath us in a posterior pelvic tilt with our pelvis swayed forward in front of our hips. And if you do that, you're going to take your pelvis kind of in this direction. And can you see that as soon as I've tilted my pelvis that way, if you think of gravity coming down from on top, I now don't have that nice shelf for my bladder anymore. So I'm going to go back to my neutral pelvis posture, and then guess what? There's my nice little shelf for my bladder. Okay? All right, so bladder. Urethra, it's really short in women and does tend to predispose us to bladder infections. We always want to wipe. Well, thank you. We always want to wipe from front to back. I'm saying thank you because she threw up my website on the comments page. Thank you for that, Shirley. We always want to wipe from front to back. We want to teach our daughters front to back. We want to teach our granddaughters front to back, and that's just to help us prevent infection, okay? Here is our vagina. Yeah, your vagina and your bladder share a wall. That wall is connective tissue and not muscle, okay? Uterus, cervix, rectum coming down at the back, and your external anal sphincter where the poo comes out. So again, can you see right there? Your vagina and your rectum share a wall, and that too is connective tissue and not muscle. So I tell people it's like condo living down there in the bottom of your body. There are separate systems right next to one another, but sometimes their functions are going to encroach upon one another. All right? Okay, so tailbone's down here at the back. Pelvic floor muscles aren't shown very well in this picture, but if they were, they make a hammock or a sling right down here from your tailbone to your pubic bone. And when they contract, when you think of turning on the muscles to stop you from peeing, or using your vagina to pick up a blueberry, or picture that your vagina is a clock and there's numbers at 12, 3, 6, and 9, and you're going to pull the numbers to the middle of the clock. That's your vagina. Those muscles, they create a pull. All muscles pull, right? So the pull that's created here goes from your tailbone forward to your pubic bone. No bones actually move when you tighten your pelvic floor. So if you've done a Kegel or your exercise and you really notice that a whole bunch of movement happened in your pelvis or your hips, that is not an isolation of your pelvic floor muscles. And you need to try again, maybe with just less effort. Okay, the things that do move, I'm gonna try to okay, there we go, center this. Your rectum, the bottom of it, your vagina, and your urethra are pulled closer to your pubic bone and up and inside your body. And that's how we keep the pee inside until we wish to go. And that's how we keep poo inside until we wish to go, is so here I come. Let's see if I can do this. We close this angle right here by pulling our urethra towards our pubic bone. We make that angle sharper, okay? At the back, there's an angle right here. Poo comes down and it has to turn a corner to come out. If we engage our pelvic floor and we pull this part of our rectum closer to our pubic bone, we make that angle very sharp and it's impossible for the poo to come out. Okay. Okay, so if we talk about pelvic organ prolapse, for instance, a pelvic organ prolapse is when these pelvic organs start to descend. There are ligaments that hold our organs to our pelvic walls on the inside, but those ligaments are kind of about front of my bladder needs to face this way, not about vertical position in space. They're not like seat belts, like our joint ligaments that help hold things in place. They're much more, I'm going to say the word elastic than that. I'm sure the tissue people in the world would have, and they might not like the word elastic, but I think in this moment you understand what I'm talking about. So the thing that holds our pelvic organs up and inside is actually our pelvic floor muscles. They do it from underneath. So it's like imagining the water underneath a ship. The water underneath the boat keeps the boat afloat. Your pelvic floor muscles keep your pelvic organs afloat inside your body. So there was a comment about, I have pelvic organ prolapse and I've seen a pelvic health physiotherapist, and they haven't been very clear to me about guidelines for exercise. And I'm sorry that you're frustrated. I'm sure it's a frustrating experience. And part of the reason for that is that it's very, very individual. What kind of exercise will be appropriate for woman A with a bladder prolapse versus woman B with a bladder prolapse? So I'll talk more about that in a second. Okay, so what does prolapse look like? It looks like, say it's a bladder prolapse, it looks like that tissue wall that the vagina and the bladder share gets a little less tensile, firm, and it starts to sag. And it sags into the vaginal space. And yes, worst case scenario is it sinks lower and lower until it comes right out. Recticell, that's called a cystocele, bladder, cystocele. Recticell is a rectal prolapse. Same thing. This posterior wall, the back wall of your vagina, becomes overstretched. That rectal space begins to sag into your vaginal space, and worst case scenario comes right out. It can also happen with your uterus and cervix, that a uterine prolapse is called a uterocele, and it starts to come down your vaginal space and can come right out. If you've had a hysterectomy and they've removed your uterus and cervix, you now have what's called a vaginal vault, and you can have a vaginal vault prolapse. And you can also have what's called an enterocele, which is that a small intestine loop, which is up here somewhere, can make its way down. It's still inside your body, but it comes out your vagina. This is as distressing as it sounds. It's pretty distressing, I'm not gonna lie. But here's the good news. A whole lot of us, and I put myself in this category because I've had a baby. So a whole lot of women who've had babies have a certain degree of pelvic organ prolapse already, because our tissues were changed by the process of holding those babies inside of us or delivering our babies vaginally, right? And we can have these prolapses and never have a symptom of it in our lives. So it's probably really underreported because women don't even know that they have them. Certain degrees of prolapse, so a certain amount of descent, can absolutely be totally assisted by physical therapy, okay? By having good, strong pelvic floor muscles that you know how to use within the context of your whole body. So if I assess you, for instance, and I find that you have a pelvic organ prolapse that is still a stage that's maybe at the door or just inside your vagina, and I retrain your pelvic floor muscles so you know how to contract it. We know that when you contract it, it lifts your organs up and inside as best they can. It may not be right back up where they belong, but it brings them up. And I know that you know how to breathe properly. And I know that you have a good connection to your core and to movement throughout your body. I'm going to feel more comfortable giving you the A-OK to go move than someone who has other movement barriers, doesn't know how to breathe, or has a more severe degree of prolapse, okay? One thing you can do, though, if you want to go and be active and you think that you have pelvic organ prolapse, or you know you do, is you can go and get yourself assessed for, fitted for, a device called a pessary. So P-E-S-S-A-R-Y. A pessary is a silicone device that's built to fit inside of our vagina, right? It goes inside, it goes inside your vagina. I have to do it this way, sorry. Here we go. It goes inside here, and it helps provide a passive support system for our organs. It's like wearing a knee brace if you've got an unstable knee. You have unstable organs, they're not staying where they belong, and you've got other movement challenges, or you're not strong, you're going to pop a pessary inside, and it's going to hold your organs up. And you're going to be able to go move, cough, sneeze, laugh, whatever, with that pessary up and inside. And I highly recommend it. So I hope that I've answered your question about why it's hard to make suggestions and why you get different answers from different people. It really is a very individual question to answer. It's really important, but it's an individual question to have answered. Okay, let's see if I've missed anything. Right from front to back, there we go. When I asked my doctor for a referral to a physiotherapist for therapy, he didn't see the benefits and said, just do Kegels. What to do? Lori, I feel for you. I really do. That's too bad. So just do Kegels. Let's talk about that phrase. 50% of us, and this is a study, it's a scientific study. They were blinded and randomized control trial, and a big subset of a population. They were given written instructions. This is how you do Kegels, and then they were tested. And 50% or more of the women who were tested, after having had written instruction, did the exact wrong thing. So they didn't just do like a poor quality contraction. They were pushing rather than contracting and lifting. So what that tells us is that most of us don't have a great connection to our pelvic floors, to this whole area of our bodies, because it's all tied up with peeing, pooing, sex, and shame, right? And we've never had anybody come along and be like, yeah, that's a good Kegel, way to go, do it like that every time. And we just, so it's not okay to say to someone, just go do Kegels, not in my professional opinion. Okay, so what to do about it? I don't know where you are, but I would like to suggest to you that you go to a walk-in clinic and talk to a different doctor. I really do. I don't know how old your doctor is, so I wonder if it's a thing about age of doctor, or perhaps a region of the world that you're in. You could give them my card and say, hey, if you've got questions about pelvic health physiotherapy, feel free to contact this person, and I will do my best for you, honey, to convince them that that's what's necessary. It's a fight, Lori, and we're trying to fight it on the ground with you. Are there any animated illustrations of pelvic floor exercises, Kegels in action? Uda, that's a great question. There are, I've seen lots of various diagrams, and I feel like I see them on social media. So you can be on Instagram, for instance, or Facebook, and type in your search bar pelvic health physiotherapy or pelvic floor muscles, and you never know what you might get. But I would imagine a lot of them. Also on YouTube. I think a lot of my colleagues around the world are trying to get the word out, and there's been a ton of stuff up on YouTube. But a specific, I don't have a link for you. Perhaps I'll look for one, and if I find one, I will post it here later. That's a great resource. If you have a hysterectomy, are you more susceptible to prolapse? It depends, Eleanor, on how they. So yes, it is a risk factor for prolapse to have a hysterectomy. A lot of times these days, the surgeon will do something called a sacrocolpoplasty. These aren't words I say every day, but so they take a piece of tissue, wrong, from what's the vaginal vault, so all this has been removed, and they anchor that area to your sacrum in some way. That was meant to be a way that a surgeon could help you ensure that you weren't going to have that greater chance of having a prolapse. So if you are bound to get a surgery, do talk to your surgeon about what about the risk of more prolapse and what do you do about it. And they should have an answer for you. Animations of internal movement during exercises, I mean. Okay, Uda, I think you heard that there. If I find one for you, I'm going to put it up there. Yeah, actually, Eleanor, a prolapse can cause lower back pain. Yes, it can. It can be related to feeling a sense of drag or heaviness, because part of the reason for a prolapse over time can be that your pelvic floor muscles simply haven't been strong enough to take care of their job, which is to contract against, I'm doing a little, so here's your pelvic floor, and there's a column of pressure on top of your pelvic floor. That's how human bodies work. We are a pressure system. So this column of pressures on top of your pelvic floor, and it's your pelvic floor's job to contract against the pressure, okay? If you've been coughing, sneezing, moving, laughing, not breathing well, not moving well for a period of time, and your pelvic floor hasn't been strong enough to combat whatever's happening, then what you get over time is descent of those pelvic organs. So if, sorry, Eleanor, stay with me here. I promise I'm getting there. And your pelvic floor is the floor of your core. And what do we need when we're considering keeping our low back healthy and happy over many, many years? We need a strong core. So I want us to just pause for a second and think about what is a core? Well, right away, you probably thought about your abdominal wall, right? You thought about your abs, and you maybe even sucked in your belly. Everybody let go of your belly. Thank you. So your belly is definitely part of your core, and it's an important part, but it's only the front of your core. The roof of your core is your diaphragm. The back of your core is some muscles along your spine. And the floor of your core is your pelvic floor. And all those areas have to move together, work well together to be considered to have a good core. So if you have pelvic organ prolapse, not only do you have something that's kind of draggy on your system, a weight, a heavy, you already, I know for a fact, have issues with your pelvic floor, and you probably have breathing issues, and maybe you have abdominal wall issues. So you might have other reasons that go along with your pelvic organ prolapse that you might have low back pain. The good news is figuring out how to correct your pelvic organ prolapse and support it over time will often take care of your low back pain at the same time. Okay, those things are related. Instead of a pessary, have you heard of using a C-sponge? I've heard of various things, even like a super tampon that you fill up with, that you soak it, you take it out of the packaging and you soak it so it's already filled up, and then you insert it. And I know this seems like awkward and messy, but it can be done. You put that inside, that can be a pessary for you and support your organs. So I have heard of C-sponges. I can't tell you that I think that's a great idea, because the medical devices that they use have been tested and used in humans, so I can't say that a C-sponge is the safest thing to put in your body. I don't know, maybe it is, but that's not advice I can give you. The tampon thing, that's definitely advice I can give you. Oh, there you go. Most of us don't have good connection. Yes, we do not. The Vagina Coach is a fantastic local resource, well, online resource. She's very pro pelvic health physical therapy, which I appreciate, because there's some things that she can't tell you about how your pelvic floor is working for you. But if your pelvic floor is working and you know how to turn your pelvic floor on and off, she can help you train it and get strong and use it well over time. After my pregnancy, I've experienced urinary retention. You pee, you think you're done, and then you pee a lot more a few minutes later. Yes, pelvic floor physiotherapy can help with this. So it sounds to me like you might have a pelvic floor that is actually weak, but it's also in a bit of spasm, like it's got too much tone, it's holding on, and you try to go pee and it doesn't know how to relax fully to let you pee. You may also have a little bit of pelvic prolapse, maybe up here, that's causing a bit of a kink in your urethra. And the kink is like a kink in the hose, in the garden hose, getting in the way of you emptying fully. And these are things that can be diagnosed by a physiotherapist. My advice to you at this moment in time is not to push. Peeing is passive. All you ladies out there who like to hurry through a pee or like to push at the end of a pee to make sure that you're empty, or if you're having this secondary voiding, this double voiding thing happening, you might be like, well, if I just push harder, I'll make it come out. But that pushing hard on things, especially a pee, which isn't necessary, can absolutely make a pelvic organ prolapse happen or make it worse. So peeing is passive, no pushing with peeing. So take your time, pee, maybe get up and move around so that your body knows there's more pee there, and then go back and sit down and relax and say, okay. It's all about taking your time and relaxing. Okay, Pam Green says, I have pelvic organ prolapse and I've been on a wait list to see a uro. All right, I think I answered this question earlier, the differences in your advice that you've received. Unfortunately, there are some challenges there. I think I have either a rectocele or possibly a rectal prolapse. I get the sensation of having to poop if I'm in the shower and I check, and I can feel a piece of softest tissue protruding from my anus. That's okay, I'm glad you're sharing. Thank you for sharing. Other people have this too, and they're too embarrassed to share, and they're so happy that you've just said that out loud. So thank you. I can push it back in. Okay. Yes, I think it's quite likely that you do potentially have a rectal anal prolapse. So I'm going to go back to mine. So that sounds like you have prolapse that's happening from here. And that is a form of prolapse, absolutely. It could also be maybe a hemorrhoid or hemorrhoidal remnant. And if you've got pressure on the back of your sphincter, that hemorrhoidal remnant blows up like a balloon. So it's not painful or itchy like a hemorrhoid, but it can blow up like the balloon. So that can be potentially pushed back in, but also rectal prolapse can be pushed back in. it's possible that pelvic health physiotherapy will help you. You can have a sphincter. So your sphincter is meant to contract at the same time as all the pelvic floor muscles around it, but it does have its own structure. So you can have a sphincter that is weak within a pelvic floor that seems quite functional. And so I often, in cases of, rectal prolapse or anal prolapse, hemorrhoids, and or constipation or fecal incontinence, teach my clients how to find and use their anal sphincter in the middle of their pelvic floor. Okay? One of the things that can happen, and sneaky, is that you turn on your pelvic floor and you go to increase the action in those muscles, and the sphincter starts to do the job it's supposed to do within that. And then, because it's just not strong enough, as the tension of the floor increases, the sphincter itself relaxes in the middle of all of that. And that's a problem. That can lead to definitely prolapse and definitely leakage. And again, that's a hard thing to figure out. And if I didn't do an internal anal assessment, so gloved finger inside the anus, and feel what the sphincter did, I would have no idea that it did that. Let's talk about pooing for a moment. Let's see here. Okay, yeah, let's talk about pooing and then we'll get to that one. Yes, I have time. Okay, pooing is really important to talk about. Pooing is important to talk about because issues with constipation and or diarrhea are, it feels to me like they're rampant these days, right? Who doesn't have some kind of GI, like umbrella IBS type diagnosis these days? And we could talk, that's a whole other office hours to talk about that. So it's an important issue, and it's definitely important when we're thinking of our pelvic organ health, because if you push against a poo that won't move every day or very hard for many, many days, weeks, years, you will absolutely cause yourself some pelvic organ prolapse. So your daughters that are constipated, get on top of that. Your sons that are constipated, get on top of that. Help them figure that out. Figure it out yourself or your partners. Okay, so I'm going to show you another picture. Pictures of poo. It's important to know what your poo looks like. So after you have a poo, you should absolutely look in the toilet. These are a group of scientists. This is called the Bristol Stool Scale. I didn't create this. This one's actually for pediatrics, but I really like it because everybody has a giggle. And if you're going to talk about poo, you probably want to have a laugh. So type 4 right here. This is what your poo should look like. That's what we're striving for. Okay? If it's on the harder end, that's a problem. And you need to go back to your fluids and your fiber and your hormones probably to help you combat that. And it's important. If you're on the bottom end of this and your stools are more watery or less formed, that can also be a problem in terms of fecal continence, keeping the poo in until the right time, but also the health of your sphincter and your pelvic floor over time. If you are worried about losing a really liquidy stool, what it tends to engender is a really hypertonic pelvic floor, super tight. That can become painful, but also less functional. So it can make your incontinence, fecal incontinence problem worse. Also, your pelvic pain worse. Maybe your intercourse pain worse, okay? So we need to shoot for this guy right here because that is the stool that has the best conversation, shall we say, with your sphincters and with your pelvic floor. It's the easiest to pass. It's also the easiest to control. Okay, so do I recommend dilators or dildos? So a dilator, sometimes dildos are, because they're penis shaped, they can be kind of not everybody's most comfortable option. So that's part of why I recommend dilators quite often. Also, I recommend dilators because you have the option to start with something small that you can accommodate to, i.e. insert inside your vagina without any pain. And if you buy a dildo and it's a certain size, and maybe it's a bigger size than your muscles or tissue can actually accommodate to, it will be painful to insert. And if it's painful to insert, it just wakes up that protective system that I talked about earlier. Your nervous system starts to get a bit hypervigilant, and your muscles get even more tense. And that can actually perpetuate your painful intercourse problem, okay? So it does depend on what you can comfortably insert. If you have a dildo at home and you can comfortably insert it, then it's absolutely an option that you can use. You would put it inside. You might do some contract and relax around that dildo that's inside because you get a whole lot of feedback. Am I doing it? Am I squeezing right now? Am I pushing it out? I don't want to push it out. I want to pull it up and inside, and then I want to let it go, right? Not push it out, just relax and let it go. So that could be a way to practice contractions and relaxations and get your tissues used to the idea of something being inside and pushing on those tissues. Thing one. And then thing two would be to use it, as I said, like a foam roller for your pelvic floor. If you Google foam rolling, if you have no idea what I'm talking about, you'll get all sorts of YouTube videos and helpful tutorials on how to use a foam roller to release muscles. And they'll be about releasing your quads or your glutes or muscles in your arms or your back. And then I want you to kind of take those principles and apply them to your vagina muscles. So these are muscles just like a quad or a glute. They just happen to be in a unique location. And we need to start to break down the sort of special flowerness of this all. These are muscles that are just like a glute or a quad. They can be trained. They need to be trained. They can be stretched. Sometimes they need to be stretched. They can be released. Sometimes they need to be. We just need to know how to turn them on and how to turn them off. So if you have your dildo and you put it inside your vagina, oh, my hands are in the way. You can then take that dildo. This is hard on a camera, but let's see. Here's my dildo, my accommodator, and this is my vagina. I'll go this way. If I get it inside comfortably, I can now use it to, by putting a pressure, I'm not going to start straight down though, putting a pressure downward and to the side. Think of a peace sign. See the direction of my fingers? You're going to aim for my index finger maybe first time. So down and to the side against the wall of muscle, not in a way that's painful. You should feel pressure, that's normal, and hold it into that muscle and tell your muscles to relax into the pressure. And then relax back to zero, back to the middle, no pressure anywhere. And then you're going to repeat that, but you're going to repeat it towards my ring finger. Oh, I'm all crooked. There we go. So down and to the side. Holding that dildo into those muscles, breathing, be really relaxed. This is not painful. Take a break. So just to demonstrate, I talked about something's in your vagina, but you can use that dilator to push on a diagonal this way, a diagonal this way, and also straight down towards your anus or 6 o'clock. And the reason that you choose down and to the side or straight down is because that's where the bulk of the muscle bellies are. So you'll have the biggest action if you do it that way. Don't go straight up. That's like your urethra is right on top of that, and then your pubic bone is there, so you'll just squish your urethra between your pubic bone and your dilator, and it doesn't feel very good. It makes you feel like you gotta pee. It's not comfortable. Don't go straight sideways even, because there's a whole bunch of bone over here and not a bunch of muscle belly. Okay, is there anything else? Oh, so much more. We'll have you back. Yes, you'll have to have you back. We're running out of time. So fluids and fiber and hormone balance, absolutely. And pelvic floor muscles are just muscles. They can be trained. So in the last couple minutes here, I'll just highlight that while I do work out of North Vancouver at a clinic called Canopy Integrated Health, I am, for 2020, coming right up here in a couple of weeks, I'm planning to open a remote branch of my practice, which means if you're in a BC community that doesn't have access to a pelvic health physical therapist and you have questions about would pelvic floor physiotherapy help me, you can book a video conferencing session with me. And we'll have a conversation. It'll look a little bit like a Facebook Live, only it'll just be you and me on a really safe, encrypted video conferencing software package whose information is stored in Canada. And we'll be able to have an assessment. I'll do a full subjective on you, be able to help you diagnose whether or not you actually need more than I could give you over video conferencing, and we can go from there. So that's kind of an exciting thing that's coming up. If you follow me on my website, which is physiogillian.com, you'll be able to see all the details about that. I'm on all social media at physiogillian, so feel free to follow me there. I put up some helpful things from time to time. You'll see what's current. I'm also planning on starting a podcast about health, not only pelvic health, but pelvic health definitely comes up in there. It's called Small Conversations for a Better World. Our trailer episode is available right now on Spotify. If you Google Small Conversations, I think you have to get to the 4, Small Conversations 4, and then it'll come up for you. And we should be on iTunes by January 3rd when we will drop our first episode. Okay, remote health and small conversations. Okay, so those are the things I wanted to talk about. I hope you all have a really great day. This has been really fun. And thank you to Shirley for putting together the Menopause Chicks universe. It's a pretty great place to be. Bye. I don't know. Oh, there you go.